We move on to the next talk in the session by Dr. SMITA Narayan. She is a presently professor at Regional Institute of Ophthalmology, Trivandrum, editor of Kerala Journal of Ophthalmology, reviewer for Indian Journal of Ophthalmology, with deep interest in the management of glaucoma. Over to you, Dr. SMITA, and she'll be talking to us on diagnostics, misleading glaucomatous optic nerve head changes.
Good morning, ladies and gentlemen. I shall be talking on some of the diagnostic modalities which may be misleading when we are doing optic nerve head analysis. So usually in a busy ophthalmology OP, we send patients for glaucoma evaluation who have either a raised intraocular pressure or optic nerve head changes which are suggestive of glaucoma. Now, we all know that the raised intraocular pressure is only a risk factor. So, the optic nerve head changes occupy the prime position for the diagnosis of glaucoma. So, it is important because when we take the patient for glaucoma evaluation in the glaucoma clinic, we usually perform an indirect slit lamp biomicroscopic examination with a 90D lens or a 78D lens. So, that is our prime method of examination. We also do a visual field and some ancillary tests to correlate that. And nowadays, many ophthalmologists rely on OCT RNFL to perform a diagnosis of glaucoma. Now, this is fraught with this is fraught with a large number of pitfalls, with a large number of misinterpretations, which can lead to situations like the red disease or green disease in the OCT RNFL. Usually, we do not diagnose glaucoma based on a single visual field printout, but it is important that we correlate with it. If we are seeing a single visual field printout, then it is not a proper way to diagnose it as such. An incorrect diagnosis, the most important thing is that it leads to unnecessary treatment. And unnecessary treatment, along with a great deal of patient anxiety and a lifelong cost for the patient. And sometimes it may lead to medico-legal issues. So first, I shall talk about some of the pitfalls that we encounter in the OCT RNFL and its interpretation. First and foremost, the OCT RNFL should be performed with at least the minimum signal strengths. The signal strengths for the spectralis are at least 15. For Cirrus, it should be at least 6. And for the RTView 30 and TopCon, it should be about 60. These are the areas where the signal strength is provided. For the spectralis, in the right eye, it is 31, and in the left eye, it is 30. So it is good signal strength. Whereas in the Cirrus printout, you can see that it is 6 in the right eye, which is just appropriate, and 5 in the left eye, which is less. So in this case, the left eye scan actually should be discarded. A good signal strength shows that the fundus picture is uniformly illuminated and you will see the details very clearly. This is not a good signal strength, and therefore you can see that the temporal part of the fundus is poorly illuminated and the details of vessels are not clear. So you see that the pie chart of the fundus in of this patient shows a red color. The B scan also shows a grainy appearance. Poor signal strength is usually associated with dirty lens of the OCT, or it can be associated with the PCO or cataract, or even with dry eye. And paradoxically, it is also associated with PCIOL. So it is important that we ensure that the patient's OCT is taken with a good signal strength. Otherwise, there is a very good chance, even though here it is temporal and it's not diagnostic of glaucoma, there's a very good chance that we can have the patient misdiagnosed as glaucoma. Second is about the ring for measurement of RNFL thickness. The center of this ring for the center of this ring for measuring RNFL thickness should actually coincide with the center of the disc. If it doesn't coincide and is exaggeratingly decentered, as in this picture, then you can see that the Tisnet profile is very abnormal. It doesn't follow the normal contour and the normal thickness. And the patient in the pie chart can be labeled as glaucomatous because of the red areas here in both eyes. But you can see that when this ring is appropriately centered, now the pie chart is green in color. And so this patient who could have been misdiagnosed as having glaucoma doesn't have actually glaucoma. More than 10% decentration should make us discard the scan. You can see this fundus picture where there is a decentration nasally and superiorly. So since the retinal nerve fiber layer is thickest around the disc and it thins away from the disc, the decentration leads to an abnormal pattern on the pie chart. So this is why this patient has a yellow or the borderline changes in the pie chart And so such a scan, so you can understand what will happen to the ISNT rule when there is decentration, because and that can inappropriately lead a person to be labeled as glaucomatous. Thirdly, in the printout, we must also look for the area just under the measuring ring. You can see a black area here. This prevents the acquisition of image in this area. And so you can see there is no image acquired in this area. This is touching the x-axis. And a floater which is present outside the measuring ring does not affect the scan, but a floater straddling the measuring ring causes an algorithm failure, a poor acquisition of the scan, and you can see that this area is now very thin and it is falsely thin. In this printout, which we had seen previously, you can see that the RNFL thickness map shows a black area here, which is a floater. This is abutting the measuring ring, and that is why the pie chart shows a yellow area, a borderline area. And therefore, this scan should actually be discarded because this has a poor signal strength of only 5 for a serous OCT. So a poor signal strength and a floater abutting the measuring area, all these lead to a suspicion of glaucoma in this patient, which is actually not there. Motion artifacts are seen when the patient has poor vision, especially if the patient is myopic or the patient has advanced glaucoma. These are best diagnosed by a horizontal line like this. These are best diagnosed by a horizontal line where there is a discontinuity of the blood vessels. These are nowadays uncommon with the newer machines because they have new sensors which prevent acquisition of the scan when the patient is moving. Cut edge artifacts, these are very common in our institution because they are operator induced and we have student technicians who take OCT. So these artifacts, which are seen especially in the periphery, there is no acquisition of data, and so these are very thin. So the machine just averages out whatever it can, and these in turn can lead to many defects, especially in patients with where you are assessing the progression of glaucoma. In the serous OCT, the cut edge artifact is seen at the periphery as the black areas like this in the RNFL thickness map. Look at this printout. You can see that the pie chart shows areas in red, which are indicative of a presence or diagnosis of glaucoma. But when you look at the Tisnet profile, you can see it touching the x-axis. And you can see that there is a complete failure of the algorithm with a poor identification of the RNFL. So this is basically an algorithm failure of the OCT. And so you have to repeat the scans. And so when the scan was repeated, you can see that the pie charts appear in green. PVDs cause traction, which causes misidentification of the RNFL. But if you are assessing progression using the OCT, you can find that it gives us an appearance of progression when it is actually not there, because as the PVD progresses, the RNFL appears to thin out on the OCT. Indian eyes have an RNFL thickness which is about 8 to 12 microns thinner than the European eyes. Since our reference database in our OCT instruments is usually of European descent, this difference in ethnicity can lead to a patient being misdiagnosed as glaucomatous. So that is another important thing that we should consider, especially for our Indian eyes. Then these are certain of those conditions where there is no normative database available. So in such situations, we should rather go for macular parameters for glaucoma. But the limitations are that there are age-related macular changes, and about 50% of the retinal ganglion cells have to be lost before we can have a diagnosis. And correlation with clinical examination is essential, which is difficult in these situations. As described by the previous speaker, they can also not only does the OCT misdiagnose many of our diagnostic techniques misdiagnose the presence of glaucoma when it is actually not there. There can be also situations when the fundus picture or the field picture shows the presence of glaucoma, but the OCT is unable to pick up. You can see that here there is an RNFL defect, which is also picked up by the visual fields, but the pie chart appears green in these patients. This is because the OCT averages out the thickness in a given quadrant, and therefore the focal defects are not picked up. In this printout, I'm not sure if it's seen clearly. You can see that there are multiple areas where the patient's testnet profile is touching the red, these two areas, but the pie chart is green. Again, this is green disease, and the OCT is unable to pick out because of the averaging. Both of my previous speakers have elaborated on how examination of the disc can be confusing in certain conditions or certain situations which are both pathological and non-pathological. And they have also highlighted how examination of the disc, especially the identification of the 5 R's, are important. The identification of the scleral rim, the neuroretinal rim, and the size and color, examination of the retinal nerve fiber layer, and examination of the peripapillary area, and also for the optic disc hemorrhages. So tilted disc has been described very well before. It is difficult to make out the presence of glaucoma in the tilted disc. Hypoplastic disc. Hypoplastic disc may give you the appearance of a global thinning, and you may think that it is like an advanced glaucoma, but again, examination of the disc will clinch the diagnosis. Myopic tilted disc, as madam has described very beautifully. I can only say that those people who have advanced glaucoma, they get multiple artifacts on the OCT RNFL, and therefore it is very difficult. It's full of pitfalls. You can see that in this OCT, the ring for measurement would be falling on the peripapillary atrophic areas, or even on these staphylomas. In this picture, on the myopic crescents, there is also motion artifact because the patient is unable to see the target because of the advanced vision defect, and also there is cut edge artifact because of the patient seating. So you can see that there are areas which show supranormal thickness, and therefore the OCT is not an appropriate way to look for myopic glaucomatous disease. But then I think it is better if we consider all patients with myopia as glaucomatous and follow them up unless otherwise proved. There has been a description about the split RNFL, especially in the superior area, where the RNFL split falls into the red area and gives a false appearance of glaucoma. Again, a diagnostic, a misdiagnosis, even though there is no glaucoma. Madam has already talked about the lateral shift. This has been described. Now, there are certain conditions which can lead to appearance of an advanced field defect, sort of a tubular field. This is a tubular field, and the patient showed a superior notch and a 0.6 cup with pale disc in both eyes. But however, on repeated questioning, the patient said that he was hospitalized for nearly a month for 35 years ago. The patient is for meningitis, life-threatening meningitis. So that has led to this infective condition has led to such tubular fields with advanced glaucoma, with advanced changes which appear like glaucoma. Sometimes very early neurological defects may mimic glaucomatous changes, as in this case where you can see there is a sort of evolution of an arcuate scotoma from a nasal defect. But in such cases, we can apply the RP Mills criteria. The RP Mills criteria are applied to the raw data of the patient. They help us to differentiate between the neurological and the glaucomatous defects. This has been already described, and so I'm not going to talk about it. Anterior ischemic optic neuropathy, that has also been described. It can lead to altitudinal defects, not necessarily respecting the x-axis. It can be above or below it. Focal retinal diseases can lead to such defects, and these are very easy to diagnose if you look at the fundus. So none of the visual field should be examined in isolation. Even peripapillary retinochoroiditis, where most of these cases would present with absolute scotomas and have sharp borders. So the take-home message is that diagnostics should not fool you. You should have a complete correlation with whatever diagnostic method you are using, but still there are some pathological and non-pathological examinations, conditions where you have to examine the patient for quite some time before you can make a diagnosis of glaucoma. Thank you very much for your kind attention.
Thank you, Dr. Smita, for the elaborate discussion on all the factors which can mislead, the diagnostics can mislead. So it is very important that we have to evaluate the optic nerve head and correlate the head optic disc findings with the field and the OCT to finally make a conclusive diagnosis.